First of all, I cannot start this talk without saying how honored I feel to be here on this stage with all of you today. And I have to say that I haven't accepted any invitation from anybody for the last 2 years. And the first time I'm traveling is for the Trivandrum Clinical Club and Dr. Jayakrishnan and all of you as well. I do miss all of you, and that's the main reason I'm here. And it may sound a little odd for you to sort of having me choose something like chronic endometritis. You may be wondering why that is a topic of importance for all of you. And the more you get to know about it, it is actually a very new topic. It's not what you think it is. It is not a chronic PID. It is something very different. And I think a lot of information is coming out in the literature for the last few years about this pathology. And this pathology is now becoming important in every field. It's becoming important for reproductive medicine patients, common problems in reproductive medicine, common problems in obstetrics and gynecology as well. Can you move this? Okay. First of all, before we start understanding what chronic endometritis is, it is actually a different phenomena from the usual PID that we are seeing. We've got to understand the concept of what a human microbiome is, first of all. And most of the information I'm going to be presenting today is maybe a little different and from what you commonly come across in the usual journals that we read. This is because a lot of it is very current literature, but most of it is very relevant studies, very good studies, and they've all been published literature in very top journals, high impact journals. So I just want you to sort of understand what the basis of this is. The basis of this is actually the human microbiome. What is human microbiome? These are human bacterial cells in the human body actually account for about 3% of our body weight. So whatever our body weight is, about 3% of this is due to the bacteria that we carry, microbiomes, microbiological factors bacterial cells that we carry accounts for 3% of all our total body weight. And these bacterial cells are also, at least in number, equal in number to the human cells. And these bacterial cells can exist as communities. It's almost like human colonies. If you take a city, you have colonies all over the city. It's almost like that. These are bacterial colonies which exist as communities in different areas of the human body. It may be in the gut, it may be in the genital tract, it may be in the oral cavity, it may be in the respiratory tract. And these colonies in each one of these areas is called a microbiome. And these microbiome in each of these areas are not just bacterial cells. They are anaerobic bacteria, aerobic bacteria, viruses, fungi. They all living in a colony in that particular area. And the human microbiomes in a particular person differ from one area to the other. What is in the gut may be different from what is in the genital tract to what is in the oral cavity as well. And the human microbiome is therefore today referred to as the other human genome. And the current concept of infectious disease is also changing. Infectious diseases have been defined as something that's caused by usually a single pathogenic organism. And that single pathogenic organism in some infectious diseases is different from what we're talking about today. And these are caused by a pathogenic multimicrobial communities or the microbiomes. So it's not caused by, these chronic infections are not caused by one single bacteria or a virus. It's caused by one of these colonies which have become dysbiotic. And these dysbiotic microbiomes have a tendency to cause what is called a biofilm in that area. We'll look at it a little later. They form a film in the normal area that they're living in, and when they become different, they're called dysbiotic, and these dysbiotic microbiomes then become the cause for diseases. Antimicrobials have decreased penetrance into these microbiomes, altered microbiomes, and the biofilm, because of the biofilm. And they do not respond to surface antimicrobials or systemic antimicrobials like other infections would do. These biofilms comprise of what is called a syntrophic consortium of microorganisms in which the cells stick to each other and also to a surface. These adherent cells then become embedded within a slimy, it's almost like a jelly with substance in it, a slimy extracellular matrix which is composed of extracellular polymeric substances. And so we have to now redefine what a normal endometrium is. Most of us have been taught for many, many decades today that there are no microbiota normally in the uterine cavity. So we've had a concept of a sterile endometrium for a long period of time. It is becoming outdated. It is outdated today. Most mucocutaneous surfaces in the human body harbor a rich flora of aerobic and anaerobic bacteria, and so does the uterine cavity. And what does this uterine cavity contain? It contains bacteria, viruses, yeasts, which are all normal flora of the endometrium, and of which anaerobes are the most dominant ones. And these uterine microbiota differ from the vaginal microflora. The odd times when you know that you've got an infection during a pregnancy or during some other time, generally we all tend to do a vaginal swab for a culture, or at the most intracervical swab for a culture. It is totally different. What is in the endometrial cavity is different from the vaginal microflora or cervical microflora. Surprisingly, the uterine microbiota are more closely resemble the oral microbiota. So therefore, you might have read articles which claim that periodontal diseases are associated with reproductive system problems, including some of the infections that you have during a pregnancy. So somebody who's harboring bacteria or the wrong kind of microbiome in the oral cavity is much more likely to develop problems during a pregnancy as well, due to similar organisms being present in the uterine cavity. And the genital tract microbiomes, if you look at it, it's not similar all over the genital tract itself either. The general characteristics of bacterial community differ from the lower genital tract to the upper genital tract. Lower genital tract, if you look at it, it's lactobacillus dominated, very high abundance of lactobacillus closer to the introitus, lower diversity upper in the vagina and in the cervix. And when you get to the uterine cavity, the lactobacillus levels become much lower, the overall microbiota levels become much lower, and the diversity, though, becomes much more. So you have more microorganisms and more kinds of microorganisms in the uterine cavity. So the prevalence of lactobacilli now have been clearly outlined, and you can see that in the lower part of the vagina, it's exceeds 90%. And it gradually decreases as it goes up in the cervix to about 97% or so. And by the time you go to the endometrium, it becomes lesser and lesser, and it becomes almost nothing in the pouch uterus. So these genital tract microbiota, the lactobacilli, play a very important part in this ecosystem. And you can see that again in the microbiota, in the lower part of the vagina, most of them produce chemical products which have more antibacterial qualities and are more acidic in nature. So in the entire human body, the pH in the vagina is the only part that has an acidic pH. This acidic pH becomes less and less. It goes up with the vagina and into the cervical cavity. So when there is an infection, it's a barrier of Where are we? Slideshow, can you change it? Yeah. So from eubiosis, by the time you go for a dysbiosis, why is it moving on its own? Okay. Has it got an auto mode on or something? It's okay, it's okay. So the biofilm is very important, and Gardnerella also has a biofilm, and as you very well know, sometimes the vaginal infections become very difficult to treat because of the biofilm in the vagina. So acute endometritis, or a PID, is something that we are all very familiar with. Common causative organisms are maybe gonococcus or chlamydia, and pathological changes that happen are neutrophil invasion, microabscess formation, and symptomatic. These are symptomatic because there is a systemic change as well, systemic inflammatory reaction causing fever, pelvic pain, vaginal discharge. Antibiotics are effective for it, common antibiotics that we use all the time for a PID, and usually they're not associated with long-term fertility issues unless they are associated with the tubal or pelvic pathology. But endometritis, chronic endometritis, is a very different pathology and seems to be associated with different kind of problems, and there is a changing perception worldwide and a lot of publications and a lot of key journals on what this chronic endometritis means to it. It is decreased lactobacillus in the upper and lower genital tract, altered microbiome, gradual entry of other organisms into the uterine cavity, and as we already said, it's not usually caused by a single microorganism. It's caused by multiple organisms existing as a community, which are called microbiome, as we talked about, forming a biofilm. And this biofilm is similar to lesions in valvular endocarditis, otitis media, periodontitis, and chronic bacterial prostatitis, where you know that single courses of antibiotics have very difficult time touching these so-called microbiomes. But the thing about them is they only cause a local inflammatory response, and there is no systemic response. Or in other words, there is no pelvic pain, there is no fever, there is not much of a vaginal discharge. No, systemically, it actually is asymptomatic infection and a chronic infection which can be there for a very long period of time and even years and years together. And common infective agents, many of them have been implicated as agents which start this with no, and again, the important thing is there are minimal or no systemic clinical signs of infection, and therefore, but however, it becomes, the diagnosis of this infection becomes important even in asymptomatic patients. And the host of organisms that can give rise may be common salts which are already in the vagina, or sometimes other organisms which are not usually in the vagina or in the genital tract. But the inflammation is only local, inflammation is not systemic, and it's a disease which is often unnoticed by patients and ignored by gynecologists because it's totally can remain totally asymptomatic, but however can produce long-lasting reproductive sequelae. Prevalence is uncertain, and now the current claim is that it may even be found in up to 40% of infertile patients. However, it may be more responsible for recurrent implantation failure in the practice of reproductive medicine and recurrent early miscarriages in the practice of general gynecology. And in cases where the recurrent implantation failure and recurrent pregnancy losses are happening, which is more than 3 as they are defined, the incidence may even jump up to 60% in some of these studies. But however, the diagnosis of this is very difficult, and it may be based on hysteroscopy, histopathological examination, microbial culture, or molecular diagnostic tools. And prevalence of infertility in them may be quite significant, and especially in the presence of situations such as RIF and RPL, which we face very often in our practices. It becomes imperative now to rule out this pathology, which is asymptomatic for the patients and difficult for you to diagnose just by doing a clinical examination, because there is no abnormal discharge, there is no pelvic tenderness that you can see, not any of the signs and symptoms which are suggestive of endometrial infection. But there are numerous reports today on the relationship of chronic endometritis to implantation inadequacy, resultant subfertility, recurrent early pregnancy losses as well. And widely varying reports is there on the literature depending on the type of patients they're looking for, and widely varying diagnostic criteria as well. Now, implantation, we'll start with implantation. Implantation, you have to have a seed and the soil, both of which are normal, which is the embryo and the endometrium. And when this process of implantation fails, we have a problem in reproductive medicine. In an IVF, you put back good embryos. Often tested embryos with normal chromosomal content with the PGT, you put them in and you don't find anything abnormal with the transfer as well, and you don't get an implantation. It fails every single time, and it goes on for the second or third time. It becomes extremely difficult to answer the patient because you haven't seen anything wrong. Most of us do a hysteroscopy as well, but it may be a casual biopsy of the endometrium just to make sure that it's okay, which is not going to tell you that there's a chronic endometritis. So it becomes very important in recurrent implantation failure now to assess the endometrium a bit more closely. Even in unexplained infertility, where you've usually done your hysterosalpingograms and you're casual looking at the endometrium, endometrial growth through a cycle, and the normal things that you look for, a tubal patency and everything else, it can be a chronic endometritis that gives rise to this kind of a problem. And these microbiome alterations have also been associated with poor IVF outcome at every stage. Okay. So when you don't find a reason, when you're putting back good embryos and you're not getting pregnancies and you don't find a reason, this could be a problem. Sometimes you may find it as a thin endometrium, and it's not a very unusual problem for reproductive medicine specialists. You may have assessed somebody earlier, didn't find any problem with the endometrium, but however, at the time of IVF, you may find that the endometrium isn't growing to what it should be growing. One of the things that you have to look for is a chronic endometritis in those kind of situations as well. And chronic endometritis and recurrent implantation failures in some of the studies are very high in number. And after that, it becomes even more important because if you do pick it up and if you do treat it, the outcomes do improve. And the impact of antibiotic therapy, which can be very simple antibiotic therapies, can improve the live birth rate, clinical pregnancy rate, and implantation rate as well. So reproductive failure can be in the form of an unexplained infertility, recurrent implantation failure, recurrent pregnancy losses, decreased implantation rate in IVF. For a lab, it can do that as well. Live birth rate per started pregnancy also. In other words, even if you do get a pregnancy, you may end up having problems through the pregnancy as well, resulting in less live birth rates per started pregnancy. And there is growing body of evidence today suggesting a link between chronic endometritis and all of these reproductive medicine problems and subfertility as well. And numerous articles have been analyzed and put through a SWOT analysis as well. And the strengths for the evidence is that there is a high prevalence in infertility of this entity if you do look for it, and the plausibility of a pathophysiological link for the bad outcome. Available diagnostic techniques are present today. It's available, but it's not just commonly looking at the endometrium with an ultrasound alone. And it also becomes a treatable pathology, which can improve the results after the treatment of RIF in recurrent miscarriages as well. Recurrent miscarriages today, for us, we do know what we do. Most of the gynecologists today, we look for thrombophilias on one side and APLA scores and the rest of it on the other side. And the last 20 or 30 years, the major discussions in the literature is whether you use progesterone blindly or not, whether that does give rise to improve, without giving a thought as to why it's happening in the first place. And has PGT improved overall incomes? The answer is actually no. Even if you choose your embryos and put your embryos in each one of those cycles, it has not shown to improve the outcome in somebody with a recurrent implantation failure. So even though that can be one of the causes, then you're left with looking at the endometrium more closely. Looking at all of the evidences, the only weaknesses are lack of standardization of diagnostic techniques. I told you that it's not easy to diagnose because you're not going to find it just by examining the patient or by the common technologies that you use. And a lot of it is operator-dependent diagnostic methods and a lack of consensus on the treatment regimen still, and absence of very large randomized studies are there. But today, most people agree that the clinical approach to recurrent implantation failure should also look at the, based on evaluation of the endometrium a bit more closely. Then what happens when these chronic endometritis that you have not addressed, it may be an IVF scenario, it may be an infertility scenario, but it may be normally conceived pregnancy as well, and can result in early pregnancy losses. Okay, not late pregnancy losses necessarily, but early pregnancy losses. But again, when you talk about it, we are used to looking for certain pathologies. We're not used to looking for endometrial pathologies in detail in early pregnancy losses. The question always revolves around usage of certain drugs. Is it progesterone? Is it aspirin? Is it heparin? Okay. A lot of times the number of miscarriages go up and the number of drugs that we use go up. Okay. And the investigations remain the same. And we still haven't looked at the detailed examination of either the embryo or the endometrium, which are the two crucial factors. So the deciduitis may originate in a pre-pregnancy chronic endometritis rather than a de novo ascending infection during a pregnancy, when it happens in a pregnancy. Again, we've all come across situations where a normal pregnancy, as we call it, not even a reproductive medicine or an IVF pregnancy, 24 weeks, everything has been okay. 20 weeks, ultrasound has been okay. No fetal changes in the growth or no changes in the Doppler studies. And suddenly this patient comes to you with preterm labor. And you don't know why she's come with preterm labor. There's no urinary tract infection that you can see. There is no vaginal infection that you can see. One possibility is actually chronic endometritis that she's been harboring, because sometimes we find that as they go on to deliver, the placenta is infected, there is evidence of infection there, and many of them show even post-delivery infections and infections happening in a postpartum period. These can be not infections which somebody contracted through the pregnancy. It may be a chronic endometritis that they started out with, which is giving rise to in the middle of the pregnancy because of the chronic deciduitis that's been present there. Because plasma cell, which is the key diagnostic factor for chronic endometritis, has been demonstrated in a lot of these cases of chronic, preterm labors and preterm deliveries after they deliver without any other known cause. They have been demonstrated in the decidua. So the compromised reproductive outcomes can also be secondary to a chronic endometritis. It can be miscarriages, it can be preterm labor, it can be PPROM, and they are, of course, more commonly, all of these are seen in IVF pregnancies as well. So all of these problems, including postpartum sepsis, post-abortal sepsis, and neonatal sepsis and associated morbidities can be secondary to a chronic infection that the woman has been harboring in her endometrial cavity without giving rise to any symptoms. But what you find is a diffuse, extensive plasmacyte infiltration in the basal plate of the plasma. It has been demonstrated in a lot of institutions today. And the likely compromised pregnancy outcome as well as neonatal outcome may be due to any of these factors. Then how on earth are you going to diagnose this? Hysteroscopy should be considered as an essential baseline test. It cannot be a very casual hysteroscopy because you're not going to find a pathology that's staring in your face. You have to look for it. But it is the basis that you start out with, the hysteroscopy. And recurrent cases of implantation failure and even in recurrent early pregnancy losses, this become a crucial test. Baseline test for RIF and RPL, which will show what looks like a stromal edema, increased vascularity, which may be local or diffuse, and especially something called micropolyps. And if you take a biopsy, the normal microbial culture may be negative. You may not find anything growing because what we are looking for in the normal microbial cultures are only aerobic organisms. We're not looking for anaerobic organisms. We're not looking for fungi. We're not looking for viruses, so it may not show anything. But it is possible in other forms of histopathology, which can be identification of plasma cells in the stroma, looking for it. And you have to work with a pathologist who will do this for you, because generally it does not get done. And it may need an immunohistochemistry as well to demonstrate the plasma cells. What we thought were the bacterial agents, and one test that was available for us was Emma analysis that came from Spain. They're not showing any benefits in diagnosing this. So what do you find in hysteroscopy? You can see those tiny little polyps in the endometrial cavity, which you may actually be overlooking. Okay, you may not be paying much attention to it, even if you're doing a hysteroscopy in all these cases, which should be a standard investigation for RIF and RPL. These are less than 1 millimeter. Unless your light is sort of slanting on the endometrial cavity, you really are looking for it, you may miss it. Look at how small those ones are, and it's very, very easy to miss them, those micropolyps. This is enlarged in a picture, magnified in a picture, but they can be found in up to 60 or 70% cases of this. And another picture which is possible is something like this, where there are multiple very subtle micropolyps all over. Edematous endometrium with these subtle micropolyps all over. And what is called the strawberry appearance. This is the increased vascularity around the gland openings, looks like a strawberry, it gives rise to a strawberry appearance. So hyperemic endometrium with central spots, increased vascular spots, and all of these together are not uncommon if you have to look for it, but then you have to look for it. So again, these are the key things which are present in a large percentage of women. Endometrial fibrosis and intrauterine adhesions are also common, but these are not like tuberculous adhesions. Sometimes even with your fluid flow, it'll open it up. Okay, it's very flimsy adhesions which may make out. See, with the fluid in the endometrial cavity, it just opens up. So they are synechiae, which can open up with your flow. And intrauterine adhesions may be found in about 8% of women with RAF, which prevents sperm migration and embryo implantation. And these may be given. This is one typical picture that most of us miss, actually, if you see it. Okay, when you're doing a sonohistogram, it becomes loculated like this. And even at the end of a period, you find a picture like this, where you know that part of this is adherent, but it's not like tuberculous adhesions. It's not like strong adhesions, they'll open up. So you do it on once, the next period you repeat it, or in between periods you repeat it and do a sonohistogram, you may not find it. So it'll come and go. Okay? That kind, this is because of those biofilms that we were talking about. It sticks to each other, but you can open it up pretty easily as well. An endometrial biopsy, what do you see? You see the same thing. You have to use a bigger curette and have to take a full thickness biopsy, not a superficial biopsy. And without anesthesia, taking it out will not be useful, so it has to be hysteroscopic biopsy. The cells in the gland of the inflammatory cells in the lumen of the glands. And the usual H&E stain will be very difficult to pick out the plasma cells. But then you can, it's almost supposed to have a spoke wheel appearance. You can pick it up, but you do have to have a pathologist who looks at a lot of sections for you and looks for all of these changes. The one thing that can work for you is immunohistochemistry, which usually is done in most of the cancer laboratories, where onco labs have this availability of this. We are making this available in a city like Coimbatore, and so can most level 2 cities also, I think. But they are available, but you have to look for it and you have to start working with the pathologist. And if you find plasma cells in the stroma, initially there was a discussion about how many should you find, but now the number needed is 1. Even if you find 1 plasma cell in the endometrium, it is abnormal. And I think when you're going to do, so I won't go into details for lack of time, receptivity should be evaluated. Tuberculous test should be mandatory in India because that can be another form of chronic endometritis. Molecular microbiology, 16S RNA, real-time PCR, RT-PCR, NGS. If you have availability of that, that can also diagnose the bacterial spectrum as well. And the RT-PCR is what you need to do for a molecular diagnosis, exact molecular diagnosis of this. It can be managed with prebiotics, probiotics, and antibiotics. And lactoferrin is the probiotic which is usually used in majority of these studies. And it should be used along with antibiotics for a good 3 months for change of the microbacteria. Otherwise, the microbacterial spectrum will remain the same and it may be very difficult. And I think the last fact is the most important fact. Only 28% of the patients will respond to a single course of antibiotics. Another 4/4 will require a second course. and another 1/4 will require a third course. So a lot of them will require repeated antibiotic therapy. Antibiotics that required are very common antibiotics that we use, but generally they have to be used for a longer period of time, along with the prebiotics and the probiotics. So the conclusion is that it's not an uncommon problem. You have to look for it in situations such as RAF and RPL, and also in unexplained infertility. It's silent, only mildly symptomatic. No systemic inflammation or manifestations is there, so it makes it that much more difficult. Significant local inflammatory response, which can be picked out by histopathology, is there, and its negative effects are there. It can have negative effects on the entire reproductive process from implantation to the entire pregnancy and the newborn as well. An accurate diagnosis today is the challenge, but it's definitely possible. And definitive treatment has been proven to be beneficial for improving reproductive outcome in all of these stages. Thank you very much.